Hello, everyone. With over 800 registrants, we have attendees from all over the world on this webinar. So good morning, good afternoon, good evening from wherever in the world you are attending this webinar, and welcome. And happy Earth Day to everyone. My name is Karen Flanders, and I will be your moderator for today's webinar. I am a metabolic and bariatric surgery nurse practitioner and coordinator at Massachusetts General Hospital's Weight Center in Boston, Massachusetts. I've been working in the specialty for a little over 21 years, and I am the past president for the Integrated Health section of the American Society for Metabolic and Bariatric Surgery. I want to thank the IFSO organizers, Manuela and Mary, for inviting me to moderate today. Welcome to this IFSO-sponsored webinar on pregnancy and bariatric surgery. What an exciting and great topic. A few housekeeping pieces first. The webinar will be recorded and it will be available starting tomorrow on the IFSO Virtual Academy page for IFSO members only, and on the IFSO YouTube channel, which is open to anyone, members and non-members. Please be aware you will receive an email with this information together with a link to download your certificate of attendance approximately 1 hour after the webinar. Attendees can type in their questions to the faculty in the questions section on the control panel. We'll try and give an answer to as many questions as possible. If your question doesn't get answered during the event, you may send it by email to the email address on this slide. Please be sure to indicate the person to whom you are addressing it to, and we'll forward it to the indicated person. And during this webinar, you will be invited to participate in some poll questions on your device. Here is today's agenda for this webinar. Before we get into the presentations and panel discussion, I would like to introduce our esteemed presenters. Dr. Dries Keulemans is from Belgium and is at the Department of Development and Regeneration, KU Leuven, Belgium, and also at the Department of Obstetrics and Gynecology at University Hospitals Leuven, Belgium. Dr. Kate Maslin is from the United Kingdom and is a senior research fellow in maternal and child health, as well as at the School of Nursing and Midwifery, Faculty of Health, University of Plymouth, UK, and is an honorary research fellow, Musgrove Park Hospital, Somerset NHS Foundation Trust, UK. And also, please meet our esteemed panelists. Maloney Shah Sanchetti, who is a registered dietitian and certified diabetic educator, working as a bariatric nutritionist for more than 10 years now. She has a few publications in the field of bariatrics and is co-director of the first of its kind online advanced bariatric nutrition course. Ms. Sanchetti is currently working as a consulting nutritionist with Dr. Aparna Govil Bashka and various hospitals of Mumbai suburbs. Dr. Lillian Craig-Steno is from the United States and is an associate faculty for the College of Allopathic Medicine, Nova Southeastern University, Fort Lauderdale, Florida. She is a dietitian working in bariatric and metabolic surgery at the Metabolic and Bariatric Institute, Cleveland Clinic, Florida, and is co-author of the ASMBS Integrated Health Nutrition Guidelines. And Liz Goodall is a bariatric dietitian at Mercy Ascot Hospital and Auckland City Hospital in Auckland, New Zealand. Welcome to you all. Let me introduce this webinar by first saying for many, pregnancy can be a very joyous time. In a normal pregnancy, women can experience a wide range of emotions, morning sickness, breast tenderness, food cravings, fatigue, and heartburn. But for women affected by obesity, pregnancy can increase potential risks and complications for both the mother, such as pregnancy-induced high blood pressure or gestational diabetes, and for the baby, such as large for gestational age. And so weight loss prior to conception will oftentimes decrease these risks. With that said, I would like to start with this first poll question. Please answer the following question on your device. Should patients with grade 3 obesity undergo bariatric surgery before becoming pregnant? This will be interesting to see what everybody's thoughts are going to be in regards to this. It certainly is an interesting dilemma that will surely bring forth more additional comments in our discussion time, and we'll save that for the panel at the end of this webinar. Okay, here you go. 78% of you feel that women with grade 3 obesity should undergo bariatric surgery before becoming pregnant, compared with 22% who do not feel they should. Interesting. Okay, so let's go to the next poll question. If a woman has had bariatric surgery, how long do you recommend she wait before conceiving? If you recommend a time range, for example, 12 to 18 months, please answer with the shortest time recommendation, such as 12 months. I think this too will be a very interesting response because there's not a lot of data out there to give a definitive time period, and we'll learn more about that with Dr. Kuhlman's presentation. Okay, wow, so this looks like the vast majority of respondents recommend waiting 18 months before conceiving after having bariatric surgery. Actually, 12 to 18 months are both the same, so interesting. And 14% with 24 months and 2% with other. I wonder what that other might be. Anyways, thank you for responding to these questions. Now let's see what Dr. Kuhlman's presentation on the do's and don'ts in caring for pregnancy after bariatric surgery will reveal.
Good afternoon. First of all, I would like to thank IFSO for having me as a speaker and providing such an international and interesting platform to discuss the current state of affairs regarding pregnancies after bariatric surgery. Now, the topic itself is becoming increasingly relevant. It is well known that the number of surgeries is increasing worldwide, but a lesser known but still important fact is the curious demographic distribution of this patient population. As you can see, more than 80% of all patients who undergo these surgeries are women, many of whom, about 50% of the total population, are of reproductive age. As such, pregnancies after bariatric surgery are becoming also increasingly common. This is something that we can be glad about in part, as the effects of obesity on pregnancy should not be underestimated. As shown in this meta-analysis, there is an increased odds of experiencing various pregnancy complications if patients are affected by obesity, such as gestational diabetes, hypertensive disorders, macrosomia, and with further increase in BMI, also an increased odds for preterm delivery and operative vaginal delivery. Now, before we can investigate whether bariatric surgery protects against these complications, we need to discuss the problem with control groups, as this differs strongly between various studies. For one, we could compare patients who become pregnant after bariatric surgery with patients who have a similar pre-surgery BMI. This will give a clear understanding of the effects of the surgery on the overall health of the patient, and is of major importance for the patients to help them understand the benefits of the surgery for them. On the other hand, we could also compare these patients to pregnancies which start with a similar pre-pregnancy BMI. This information is more relevant for the clinician who is involved in the care for these patients, as we are not so confronted by the complications that were prevented by the surgery, but more so by those inherently caused or associated to the surgery itself, because those that were prevented, we don't see. To illustrate this, I would like to show you these data from a meta-analysis by Kwong and colleagues, in which they compared pregnancy outcomes of patients after surgery to controls matched in part to pre-surgery BMI, the blue lines on this slide, and in the pre-pregnancy BMI, the red lines. And as you can see, at the very top of this slide, there is a significant decrease in the odds of having gestational diabetes during pregnancies after bariatric surgery when we're comparing these patients to patients with a similar pre-surgery BMI. This effect is not noted when we compare them to patients with a similar pre-pregnancy BMI. This would implicate that the reduction in weight caused by the surgery is the main driving factor in reducing this risk. The same can be said about hypertensive disorders in pregnancy. On the other hand, you can see data on, for instance, small gestational age babies, SGA. The odds of having an SGA baby is similarly increased when compared to pre-surgery and pre-pregnancy BMI. And this would mean that the surgery itself has an effect on the pregnancy, which alters the course and the development of the fetus when compared to patients with a similar BMI. This effect is also seen in macrosomia, which could be beneficial, but also on things like preterm delivery, which is of course not beneficial. For some outcomes, however, this methodology of comparing them to both controls groups is not possible, however, because some outcomes are too rare to achieve sufficient events. For instance, Zeynep Akhter from the University of Newcastle performed an extensive systematic review in which he investigated things like perinatal mortality, which is slightly increased after bariatric surgery, as shown on this slide, and also congenital anomalies. Based on all these findings, we can state that bariatric surgery significantly protects the patient from pregnancy complications due to obesity. But there is a trade-off. Certain complications specific to surgery can arise. So we need to acknowledge that this growing group of women is in need of a tailored approach to the follow-up of their pregnancy in order to come to the best results. As such, I would like to go with you through the various stages of pregnancy and discuss special points of attention that you need to acknowledge. We will start right after surgery and in the preconception period, and we will end in the postpartum. This overview will be based on recommendations published in open access, so it is readily available for those more interested in the subject. We, as a part of an international group of researchers, performed an extensive review of the literature and used this to answer various questions that we were confronted with when taking care of these patients. I certainly need to thank Gilles Shaw for this, because her help in realizing this project was tremendous. Okay, so as I mentioned, we need to start thinking about the possibility of pregnancies right after or even before surgery. It is known that pregnancies that occur within the first 12 to 18 months after surgery are at an increased risk of experiencing complications such as the small gestational age babies and preterm delivery. As no real cutoff can be defined in literature, we suggest a pragmatic approach of postponing pregnancy until a stable weight has been achieved. Of course, this can only be done if we also give proper counseling on contraception. And it is our job to remind patients that this will be an issue, because they are often not aware of this. Obesity has deleterious effects on fertility, and many patients don't have a cycle anymore, and they don't realize that they can get pregnant rapidly when their weight plummets. If you combine this increased fertility with also the possibility that they have more sexual interactions because they have an improved body image, and the fact that contraceptive drugs might not work as well, we can end up with unplanned pregnancies. Now, on this last point, the contraceptive drugs, I need to elaborate on that a little bit, because the malabsorptive properties of bariatric surgery, combined with possible nausea and vomiting, can seriously limit the effectiveness of oral drugs. So when counseling your patient, be aware of this, and it is better to choose for those types that are not dependent on this, such as IUDs or implants. And it is always an option to place these implants or these IUDs when patients are under sedation for the surgery itself, which is a very elegant solution. Being able to plan the pregnancy with proper contraception is also important, as it gives us the possibility of preparing and counseling our patients for this special period in their life. For instance, we can screen our patients for micronutrient deficiencies and provide adequate supplementation, which is adapted to the increased needs of pregnancies. As such, we can make sure that the developing fetus has all it needs in the first weeks of its life, when many patients don't even are aware that they are pregnant. And although this subject is very important, and we cannot stress the importance of this in the follow-up of patients enough, I, for one, will not further expand on this, as my colleague Kate Maslin will do so more extensively. What I will discuss with you is the special attention that should be given to mental health disorders in this group of patients. Based on data from our own prospective cohort, we have seen that patients after bariatric surgery experience anxiety more frequently and more intensively than their non-surgical counterparts. The exact reasons for this have not yet been revealed, but possible explanations could be that patients are worried about the effects of the surgery on their babies, or that changes in the body image due to the renewed weight gain of pregnancy itself have some effect. Otherwise, some underlying conditions can make them more prone to experiencing mental stress. Most likely, it is a combination of various factors such as these. Either way, you should be vigilant about it and promptly offer follow-up by a trained psychologist or psychiatrist with experience in the mental health disorders during pregnancy field when indicated. Okay, now you're finally there. Your patient has waited the required time, micronutrient status is sufficient, and mental health has been properly investigated. Now your patient is pregnant, and the real follow-up starts. In the first trimester, your main job will be to observe and be vigilant. Besides the regular care of pregnancy, you should also check for micronutrient deficiencies at least once every trimester. And if your patient experiences heavy vomiting, which is a well-known complication of pregnancy, you should always check vitamin B1 deficiencies, as Wernicke encephalopathy can occur in these cases. Furthermore, we recommend checking a fasting plasma glucose level in the first trimester to exclude pre-existing diabetes, and you should start weighing your patient to have an idea of gestational weight gain. I will elaborate more on these points later in my presentation. Most importantly, you should be aware of the risks of surgical complications during pregnancy. Small bowel obstruction due to internal herniation after gastric bypass surgery sees an increased prevalence during pregnancy, with studies reporting this complication in 2 to 11% of all pregnancies. This is a lot. Diagnosing this condition can be difficult because the complaints often mimic those already there when you're pregnant, like abdominal pain or abdominal discomfort, nausea, and vomiting. Diagnostic tests such as CT scans are often delayed because care providers don't want to harm the patient or the baby with these radiations. When they are performed, the sensitivity of these tests is also not ideal. Furthermore, treatment, such as mainly surgical intervention, is also delayed because of the pregnancy, and this can lead to a high mortality and morbidity in these cases. To summarize, the easiest way to put it, every pregnant woman with a history of bariatric surgery, mainly gastric bypass surgery, who experiences abdominal pain, has an internal herniation until proven otherwise. And when you're severely suspecting this to be the case, you should offer prompt treatment. Now, all the previously discussed points remain relevant during the second trimester, but some specific investigations should also be performed. Namely, all patients after bariatric surgery should be screened for the possible gestational diabetes. As I mentioned earlier, bariatric surgery appears to reduce the risk for this complication when compared to patients with a similar pre-surgery BMI, but patients still experience residual decrease of obesity, meaning that the risk for GDM is still increased when compared to the general population. The way patients should be screened does differ from other pregnancies, as this is usually done with an oral glucose tolerance test, in which patients ingest 75 grams of glucose, but previous research has shown that about 65% of all patients experience adverse events after this test due to dumping syndrome. Moreover, reactive hypoglycemia may be seen, affecting the overall results of the test. Lastly, using this test would lead to a diagnosis of GDM in about 50% of bariatric patients without this condition affecting pregnancy outcomes as expected, meaning that the diagnosis is probably faulty. This has led to a more pragmatic approach in screening for GDM after bariatric surgery, which you can now see on this slide. So we start, as mentioned, with a screening for pre-existing diabetes in the first trimester using a fasting plasma glucose because it's the most reliable test. If this is not feasible, you can use HbA1c, but results might not be as reliable. Either way, in second trimester, we recommend screening for GDM using a 7-point capillary blood glucose level or continuous glucose monitoring. Cutoffs for the diagnosis are similar to those proposed by the AEDP. If the diagnosis is made, follow-up should be tailored according to general local policies. A second point of interest during the second trimester is the special attention that should be given to fetal growth and fetal development. As mentioned earlier, the risk for SGA is increased, and so is the risk for the congenital anomalies. Detailed scans should be offered to screen for these possible anomalies, and they should be repeated during the third trimester to check for late pregnancy complications, such as fetal brain hemorrhage. We also recommend checking fetal growth on a monthly basis from viability onwards. It is of note that fetal growth patterns after bariatric surgery differ from those seen in patients with obesity or those with a similar BMI. These pictures are taken by a study from Jelle and show the growth rate of fetal subcutaneous tissue thickness between various groups. And as you can see, fetuses born to mothers after bariatric surgery experience a much more limited increase when compared to various controls. The effect is even more pronounced when plotting the subcutaneous tissue thickness versus the abdominal circumference, which shows a relative decline in patients after bariatric surgery. The meaning of these findings is not entirely clear as of right now, but they might indicate that the mechanisms of growth restriction after surgery differ from those seen in non-surgical patients. Further research on the subject is needed before valid conclusions can be made, so for now, follow-up of fetuses found to be growth restricted should be performed according to valid international guidelines. Lastly, as I pointed out earlier, you should measure maternal weight gain during pregnancy and attempt to achieve weight gain according to international guidelines by the Institute of Medicine. I now show these here on the slide. This is not always easy, as we have seen in our own cohort that only 20% of patients achieve this goal, and most patients, about 56% of them, gain more weight than recommended, increasing the risk of postpartum weight retention. On the other hand, gestational weight gain, which is lower than recommended, is also not ideal. In this figure, we plotted the birth weight of children born in our cohort and calculated how many were SGA, meaning having a birth weight lower than the 10th percentile. As you can see, we found that almost half of all patients with insufficient weight gain had an SGA baby, and as such, one should be extra vigilant for this complication if weight gain is too low. Okay, now you're almost there, third trimester. At this moment, nothing new happens, but this does not mean that your work is over. Continue screening for micronutrient deficiencies, mental health disorders, fetal development issues, and surgical complications. If you do your job right and everything goes according to plan, you will hopefully end up with a happy mother and a happy baby. As there is no specific guidance on the delivery process, we will jump right into the postpartum periods. At this moment, new attention should be given to contraceptive counseling, and furthermore, patients who are diagnosed with GDM should receive proper follow-up. Breastfeeding and postpartum weight loss are also two very important issues at this moment, but these will be discussed in the presentation of my colleague, Kate Maslin. As such, I leave you with this overview of our recommendations, also found in our open access publication. I would like to thank you for your attention, and I'm looking forward to any questions that you might have.
That was an excellent presentation. Thank you very much, Dr. Ceulemans. Just a reminder, we will have a panel discussion and answer questions after the next presentation. But before that presentation, let's ask the next set of poll questions. Remember to answer the questions on your device. Okay, in your setting or service, do those who become pregnant after bariatric surgery receive nutritional monitoring advice? Yes, we have a specific specialist antenatal clinic/service for this patient group, or they receive routine nutritional advice as standard care, or it depends how long it has been since their surgery, or I don't know. Let's see what everybody's recommendations might be with this. Okay, so here are the results. Looks like the majority responded that they receive routine nutritional advice as standard care, And second, very close second, yes, we have specific antenatal service for this patient population. Okay, let's look at the next question. What advice do you give regarding breastfeeding in the postpartum bariatric population? Would generally recommend breastfeeding as per World Health Organization advice. Would generally recommend formula feeding. No particular advice, it would depend on patient preference, or I don't know. It would also be interesting to see if this correlates with the same advice given for the non-bariatric patient. If it were the same, that would be an interesting study. Sorry, Kate. Okay. So many of the attendees recommend breastfeeding as per the WHO advice. And second, very distant second, I apologize, no particular advice. It would depend on patient preference. Well, thank you again for responding to these poll questions. Now let's see what Dr. Maslin's presentation will divulge about the nutritional aspects of pregnancy after bariatric surgery.
Hi everyone, my name is Kate Maslin. I'm a Senior Research Fellow in Maternal and Child Health and Dietitian based at the University of Plymouth, and I'd like to really thank the organisers for inviting me to speak today. I know we have a very wide international audience from all over the world, so just to show you geographically where I'm based, I work at the University of Plymouth, and the data I'm going to be presenting is from a group of patients who attended a clinic in Taunton, which is in Somerset, also in the southwest. So the first part of my presentation is going to be a retrospective data set. For those of you who are based in the UK and may have attended the BOMS conference in Aberdeen last year, some of that will be familiar to you. But the second half of the presentation is going to focus a little bit on some of the research gaps pertaining to postpartum health after pregnancy, after bariatric surgery. So I know the presentation we've just had from Dries has really given a great overview all about the do's and don'ts in pregnancy after bariatric surgery, but I'd like to really just focus on some of the nutritional deficiencies first of all. And if we look at this systematic review, which was undertaken in 2015, we can see that some of the nutritional deficiencies that can occur in pregnancy after bariatric surgery can be really quite severe and can have some very damaging consequences for the neonate. But actually, when you look a little bit in more detail, a lot of this evidence that links maternal nutrition deficiencies to fetal outcomes is actually not really designed to collect isn't really designed in the correct way to collect the information as we would like to see it. And this is mainly because a lot of the studies that were included in this systematic review were based on case reports. And we know there can be an element of publication bias with these type of studies. So the data I'm going to present to you now aimed to describe and characterise a case series of women in the UK who became pregnant, attended a medical antenatal clinic and gave birth following bariatric surgery. And we're interested in looking at all the following perinatal outcome measures. And at the time when we collected this data and when we published it towards the end of 2019, there actually wasn't any data published using a UK population. And I know that just a couple of months ago, a larger study has been published by Katie Cornthwaite and some of the team at Bristol. And this was published in the European Journal of Obstetrics and Gynecology and looked at a bigger national cohort. So I'd encourage you, if you're interested in this, to go and have a read of that article also. So for our data, we were interested in looking at routine clinical information. This was collected retrospectively from the medical notes of women who had bariatric surgery and subsequently delivered over a 6-year period. And all of these women were seen in a multidisciplinary medical antenatal clinic. And this clinic included an endocrinologist, an obstetrician and dietitian. And the people attending this clinic were invited to attend in the first and in the second to third trimester. So normally the appointments took place around 12 weeks of pregnancy and around 28 weeks of pregnancy. So we collected data based on the first pregnancy that occurred after bariatric surgery. So actually over a 6-year period, there were more than 60 pregnancies, but some of those were in women who had had more than one child. So the majority of patients were white British. And if you look at the surgical procedure in this particular setting, the most common procedure was gastric banding, accounting for about half of patients, and a lesser extent gastric bypass and sleeve gastrectomy. And looking at the weight trajectory, you can see the BMI pre-surgery was approximately 45, and the BMI at booking appointment, and this is the appointment that occurs typically around 8 weeks of pregnancy, BMI had dropped to between 30 to 35. So we've already heard a little bit about time to conception and when is the optimal time to conceive after bariatric surgery from a nutritional and fetal health point of view. In this cohort, we found that about 27.9% conceived in the first year after surgery. However, we need to really bear in mind that this was all retrospective data. We don't know about contraception, we don't know about family planning intentions, so it's difficult to draw any particular conclusion looking at this type of study design. And then again, looking at preconception supplementation with folic acid, less than half of patients were taking the recommended 5 milligram dose when first seen in the clinic. However, we don't know, this data collection occurred around 12 weeks of pregnancy, so we don't actually know if they were taking this beforehand and what advice had been given. So as a dietitian, I was particularly interested in the intake of micronutrient supplements. You can see the darker color blue bar is at appointment 1, so around 12 weeks of pregnancy, and the lighter color blue bar is around 28 weeks of pregnancy, and around 80% of patients attended both of these clinics, so there was a little drop off in terms of people attending. So if you look at this red box, you can see that around 80% of those attending this clinic were taking some form of multivitamin and mineral supplement. However, when you drill down into that a little bit more detail, the first appointment, about half were taking a pregnancy-specific multivitamin and mineral, which in most cases is probably not sufficient for their needs. But after the appointment, when they came back to the second appointment, you can see that a lot more were taking a complete micronutrient supplement. So the advice obviously was given to stop the pregnancy-specific multivitamin and mineral and to take a more suitable complete micronutrient supplement. Again, you can see from the first to the second appointment, significantly more patients were taking iron and vitamin B12 injections, and this differed according to surgery type, as we would expect. When we look at micronutrient biomarkers, we particularly looked at iron and vitamin D statuses. And you can see that more than half had suboptimal iron and vitamin D statuses. And we know that in pregnancy, generally, in the general population, anemia can affect, between 1/4 and 1/2 of women, and it has really severe consequences. So anemia in pregnancy can cause perinatal death and stillbirth, so it's really not something that should be ignored. But thankfully, we found in this cohort that from the first to the second appointment, the percentage of women who had anemia fell from 56% to 13%, and overall 10% required an iron infusion. But interestingly, iron did not differ by surgery type or time to conception, but as you would expect, it was more common in those who were not taking iron supplements. So looking a little bit at gestational weight gain, and for the purpose of this data, we defined insufficient, appropriate, and excess gestational weight gain according to the IOM recommendations. And gestational weight gain was measured from the beginning of pregnancy to the last recorded weight in pregnancy, which was usually around 38 weeks. And just looking at the start of pregnancy, you can see more than half were in the obese category according to BMI. And the numbers of patients you can see is small, the sample size is small, but we do have this trend, which I think is worth pointing out, that those who were a healthy weight at the beginning of pregnancy were more likely to gain insufficient weight, and those who were in the obese category at the beginning of pregnancy were more likely to gain excessive gestational weight. So we have this very divergent pattern of gestational weight gain, and we have the extremes where we might have both over and under nutrition occurring. And we see this in the general population as well. So it's just worth highlighting that we do have both extremes. And interestingly, gestational weight gain did not differ by surgical type, and it also wasn't correlated with infant birth weight or gestational age. Okay, so overall, looking at perinatal outcomes from this cohort, they were very positive, and I think this is, attributable to the fact that these patients received really good care, individualized advice from the team at this medical antenatal clinic. So very few were born preterm, and very few were born with, extremes of birth weight, either macrosomic or small for gestational age. And about 63% were breastfed at birth. So the national average in England is about 80% of infants are breastfed at birth, and I'll talk about this a little bit later. Okay, so two other aspects I'm just going to discuss with a few slides about each. So the first one is postpartum weight retention. And I think before we start to consider postpartum weight retention in the post-bariatric population, we need to really consider what is considered healthy or normal in the general population. And we need to discuss this, in the context of all the pressures of being a new mother in terms of the physical, emotional, and social difficulties that can occur kind of immediately after birth. So it's not about putting in strict targets or pressurizing anyone to lose weight. But to be honest, we don't really have a strict definition about what is considered the postpartum window. It's either defined as 6 weeks, 6 months, 12 months. If you look at different studies, different standards, there's no consensus on what is considered the postpartum timeframe. Okay. So how soon should it be recommended that after pregnancy that pregnant women postpartum women return to their pre-pregnancy weight? Does this matter? And what does this mean health-wise? So we can look at a couple of systematic reviews to give us some insight. So this one, which was published in 2011, found that those with gestational weight gain above the IMN guidelines retained an additional 3 kilograms after 3 years and 4.72 kilograms on average after 15 years. So there's definitely a trend that higher gestational weight gain leads to higher postpartum weight retention, and that makes sense to a certain extent. It's also really important to look at interpregnancy weight change, because we know that many people may wish to go on to have subsequent children. So it's not just about the index pregnancy, it's about thinking about future health in future pregnancies. And this is really interesting. 2 different systematic reviews and meta-analysis, one from 2019 and one from 2020. And they found that the greater interpregnancy weight gain is consistently associated with higher risk of perinatal complications in subsequent pregnancies. And in terms of interpregnancy weight gain, they're talking about a 3-unit increase in BMI. And what I find most interesting in this is that the biggest risk is in those who started their first pregnancy with a BMI below 25. So it's not about those who start their first pregnancy already with an overweight or obese BMI. The highest risk is in those who started the first pregnancy with a BMI under 25. So if you had a patient, for example, who had had bariatric surgery, they had reached a BMI, let's say, of 24, and they then become pregnant and retained weight going into the subsequent pregnancy, they're actually at higher risk. And I'd encourage you to read these 2 systematic reviews if you want to find out more information about that. So that's in the general population. What about in the post-bariatric surgery population? So as you would expect, little is known about postpartum weight loss in women with a history of bariatric surgery. Often it's an exploratory factor in studies, and this is because studies don't tend to go on, continue much past 12 months past birth. And there's a bit of debate in the studies that do exist about whether pregnancy contributes to long-term excess weight gain or loss. But we do know from a study that Dries has conducted that postpartum weight retention is associated with excess gestational weight gain. So overall, you know, how best can we support those in the post-bariatric surgery at postpartum weight loss? We need to be pragmatic. We need to look about the best available evidence. And, you know, I'm aware this advice is quite simplistic, but I think we should be looking to encourage appropriate gestational weight gain within the IOM guidance, bearing in mind that this may mean, you know, very little or perhaps even no weight gain in pregnancy, depending on the pre-pregnancy BMI. Encourage dietary and lifestyle choices that support them to return to their pre-pregnancy weight. And in many cases, individualized advice will be required. And this is going to be highly dependent on the type of surgery, time frame, comorbidities, and so on. And, you know, I stress that this advice has been extrapolated from the general population, and we really need bariatric specific studies and definitely qualitative studies to see things from the patient perspective. Okay, so just quickly to talk a little bit about breastfeeding and lactation post-surgery. So we know that from the literature, breast milk is usually sufficient to support infant growth in the first 6 months of life. There's no convincing evidence that milk production and/or quality are affected by either mild or moderate variations in maternal nutrition. There is some evidence to suggest that maternal BMI and adiposity can be associated with higher fat and lactose concentrations, but again, the study quality is poor. So the evidence is not necessarily there to show that maternal nutrition is going to be influencing breast milk quantity or quality, and this is in the general population. So what about in the post-bariatric surgery? So really, we don't have data. I feel like I'm saying that quite a lot, but there's really limited data available on breastfeeding after bariatric surgery. If you look at the data from across different cohorts, results are limited to a couple of observational studies with small sample sizes. And you can see we have in the first box here, we have some data from the Aurora study in Belgium, and they show that the composition of breast milk after surgery is largely comparable to those without prior bariatric surgery. There's also other studies that look at the children who have been breastfed, and on the other side we have case reports that have highlighted adverse infant and maternal outcomes post-bypass surgery related to vitamin B12, zinc, vitamin A, iron and protein deficiencies. But I stress these are case reports and they are the extreme end. And this is another study just from last year based in New York, and this showed that nutritional deficiencies in those breastfeeding after bariatric surgery may in fact be less common than those who haven't had bariatric surgery, so that provides a bit of context as well. And just on the other side of that, we know that women living with overweight or obesity are less likely to initiate and continue breastfeeding than healthy weight women. And we know the positive effects breastfeeding can have on postpartum weight loss and the protective role in the prevention of childhood obesity. So overall, what should we be recommending? Overall, the message is that breastfeeding for at least 6 months should be recommended as per the WHO guidance, but that maternal nutritional status should be closely monitored during lactation, and additional supplements may be prescribed, may be necessary. Okay, so to summarize, pregnancy in the catabolic phase soon after surgery when nutritional deficiencies are exacerbated has the potential for poor fetal outcomes. However, from our data, from the southwest of the UK, we have shown that nutritional supplementation practices improved following attendance at a multidisciplinary antenatal clinic, and we had very positive perinatal outcomes. So ideally, individualized follow-up should be provided with nutritional monitoring. We recommend that encouragement and support should be provided to encourage those who've had pregnancy after bariatric surgery to return to their pre-pregnancy weight and to breastfeed for at least 6 months, but there's a lack of research and definitely a lack of qualitative research around this topic. And overall, we have a lack of data about women's reproductive health following bariatric surgery. We need prospective data really to help find out more about all these different topics. So thank you very much to my colleagues and collaborators, and thank you very much for listening.
Wow, thank you very much, Dr. Ceulemans and Dr. Maslin, for your insight and information on pregnancy and bariatric surgery. We've got lots of questions that are coming in, and our panelists have some discussions to share as well. So let's go ahead and get started. I think some of these questions have already been answered in your presentations, but let me just recap some of them. One of the questions was what to do for testing for gestational diabetes. Dr. Ceulemans, you offered this information in your presentation. that the 7-point capillary blood glucose profile or continuous glucose monitoring for 1 week between weeks 24 and 28, and or monitoring the A1C every trimester. Anything different you want to add in regards to that?
No, not really. I think it's quite clear, that fact.
And the same thing, there was a question about what you would recommend for birth control. You too also addressed that, in that you recommended long-acting reversible, such as the IUD. Again, anything further you want to add to that?
Maybe one point, because of course these are types of contraceptive drugs that can be used for a very long time, and sometimes patients are more searching for something short-term. Like immediately postpartum, they don't want to wait for 5 years before getting pregnant again. So then you're looking for something else. And this is always the difficult point, because as I said, the oral drugs might not be the best choice. And in these patients, we sometimes have the option of using things like a vaginal ring, which contains hormones. But I do have to stress that in these cases, you should look at each patient individually, because of course, these types of contraceptive drugs might increase thrombose risks. And if your patient still has residual degrees of obesity, you should take this into account. But in general, we find that IUDs have a very high acceptance rate and are very popular in our patients.
Okay, thank you. Dr. Maslin. Lots of questions coming in about vitamins. And so I'm going to turn to you and ask you if you have any particular vitamin that you might recommend, and or minerals, and the panel as well, if you have any recommendations that you may offer. It seems we get a lot of recommendations coming from all different disciplines. The surgeons may be saying one thing, the dietitians might be saying something different, and OBGYN may be saying something completely different. So any recommendations you may have in regards to a good vitamin and or mineral supplement, and also if you could address vitamin A and the deficiencies associated with it, and how to replace it if you have that recommendation.
Yeah, sure. So yeah, it's quite a complicated issue. In my presentation, you can see I differentiated between the general prenatal multivitamin that you can buy over the counter everywhere. Those type of preparations usually have vitamin A in the beta carotene form, and they may not necessarily have enough of the other micronutrients depending on what procedure the pregnant person has had. In the UK, we often use a complete multivitamin and mineral that also contains trace elements. One of the ones we might use is Forceval capsules, and that has the majority of the vitamin A in beta carotene form. Obviously, it will depend where you live, what's available, what's on prescription, and what's affordable. Another thing that often comes up is about folic acid. So should it be the 5 milligram or should it be 400 micrograms? And this will again depend on the person's BMI and also their procedure and what the recommendation is in your country. So I would encourage you to look at the paper that Dries showed. So the one that Dries and Jill Shaw are the lead authors on, that has a nice table that goes through each one. And also in the UK, we have the BOMS guidelines that were updated in 2020 that also has a specific table for pregnancy and preconception.
Thank you. Yes, Dr. Craig-Stino.
Thank you. First, I want to congratulate both of the presenters for a very thoughtful, amazing presentation. Thank you so much. And thanks for IFSO for allowing me to be part of the panel. Getting back to some of the vitamins, I just, and this is addressed to both, the folic acid, I just want to have a better understanding. I know the recommendation is up to 4 to 5 milligrams, which is about 4 to 5 times higher than the USA recommends for pregnancy. So I just wanted to understand the rationale to that high of a dosage, and if there's any concern with masking a B12 deficiency, especially in a sleeve gastrectomy or a gastric bypass or more malabsorptive procedure. That's question number one. And then my second question would be, a lot of the OBs here in the US for pregnancy, what they feel comfortable doing is still recommending a prenatal vitamin for their moms, especially on patients that have the more restrictive rather than malabsorptive, and then substitute with individual nutrients, because they feel that the prenatal is still designed specifically for the fetal development. A lot of the general multivitamins here in the US, or even a bariatric multivitamin, would be inappropriate in terms of the type and form of the vitamin. So would you agree with that rationale, or just want to hear your comments on that? Thank you.
Great comment. I'll go first, and then I'll let Dries chip in with anything else he wants to add. So the B12 comment, that's something I missed out. So in our guidelines that we have in the UK, that is one of the things to check vitamin B12 beforehand as well, to check for signs of masculine deficiency. So thank you for pointing that out. That's a great comment. And the second question, with regard to the general prenatal multivitamin, I definitely think it should be assessed on an individual basis. Also, just anecdotally, things like the very high iron dose can cause nausea and vomiting. So I think, yes, you're correct to individualize that and to consider whether you should have a general prenatal preparation with then additional iron and vitamin D or whatever else is lacking. Yeah, it's difficult to give general advice versus a blanket message compared to very individual advice, but I think both approaches are warranted.
Thanks, Dr. Maslin.
I speak from Belgium, and in Belgium we have a very luxurious situation because we actually have a multivitamin on the market that is specific for pregnancies after bariatric surgery.
Wow.
So we were able to work with the industry and look at all the available data that was there, use data from our own cohorts to see what type of deficiencies that we noted and how much supplements should be given to address for this. And based on these findings, we developed something. And that's going to go into a prospective cohort. So we're very curious what's going on with that, but we have the impression that we have less deficiencies since we started using this.
Thank you.
Question for you. The India guidelines suggest that the incidence of nutritional deficiencies is higher in Indian population. So does this present additional challenges?
I don't completely understand the question.
Well, I was hoping Maloney could address that. Do you have any? We can't hear you.
Could you please repeat the question, because I couldn't actually hear the entire question.
Okay. The India guidelines suggest that the incidence of nutritional deficiencies is higher in the Indian population. So does this present additional challenges? And if so, please.
So, yes. So thank you for this question. So basically, when we look at the Indian population, we've really seen that the higher incidence of B12 and D3 deficiency is really high in Indians. So for the Indian scenario, when a patient undergoing a bariatric surgery, we would make sure that the B12 levels and the D3 levels are given separately. So they are supplemented separately to these patients. So in case if the patient is planning to conceive, we make sure that these levels are checked well before they go ahead for conception. So that is one thing. And as a rule, we give all our patients general multivitamin, multimineral supplements. So we don't really have a different pregnancy multivitamin to provide these patients.
Thank you.
Yes.
Okay. I have some more questions coming in here. So let me direct this to Dr. Ceulemans again. Do you think the increased intra-abdominal pressure of pregnancy is the reason for increase in internal hernias? 11% is very, 11% is very high. And would you advise a woman of childbearing age to have a sleeve instead of bypass?
That's a very common question. So 11% is indeed very high for a very serious complications. So we should always be aware of this. As of the reasons why we see this increase, it's probably the intra-abdominal pressure. Of course, we don't know for sure. We can only see what's happening. But based on this, I would indeed suggest bariatric surgeons to opt for sleeve hysterectomy in patients of reproductive age. Also, of course, this is never very clear because there's no real trial going on for the moment comparing sleeve and bypass in this aspect, but hopefully we can do it in the future once we have some funding. And I hope that I can then give you the perfect answer to that. But in the meantime, I would be cautious, and I would suggest doing sleeve gastrectomy, certainly because it also is an excellent profile for weight loss.
So good answer, but now I have another question, and it has to do with weight loss and weight loss surgery after a woman has had a baby. How soon after having a baby would you recommend having weight loss surgery?
This is also a difficult but good question. So the general answer is to look at your patients, I think. It depends if the woman is breastfeeding. If she is breastfeeding, I would not recommend doing the surgery then, although there are case reports when this happened and the results in case reports were not very good. So otherwise I would start looking at that, but otherwise, if the patient has stopped breastfeeding, I think after 9 to 12 months, it could be an option to do it. If the patient still has time to go to the necessary follow-up consultations. So I think a year, that would be sufficient.
All right. For our dietitians, if a patient discovered being already pregnant after bariatric surgery, what do you recommend? Is it safe to use protein supplement? Or Dr. Ceulemans, I'm sorry, I don't mean to leave you out either.
No, perfectly happy.
Well, I guess I can start the conversation. I think protein supplementation is perfectly appropriate to meet the patient's nutritional needs. After we do a full nutrition assessment as to what the patient is able to tolerate with whole foods, of course, we might need to fill in the gaps, and that's why supplementation, I think, would be important.
Yeah, I think the recommendation for protein generally used is about 60 grams per day, but that has been extrapolated from the general population. It doesn't have a huge amount of evidence-based pregnancy-wise, but in some research I've done looking at what pregnant women actually eat after bariatric surgery, quite often the pregnancy, estimated requirement of 60 grams isn't actually being met. So, yeah, I think you need to have a food-first approach, but also consider supplementation too. Sorry, Liz, were you going to?
Oh yeah, I agree. In New Zealand, we're exactly the same. We recommend some protein supplementation if we need it. But I think there's a little bit of research that's looking at that macronutrient balance in pregnant women as well. It's not bariatric specific, but there's some research that suggests having more than about 20 to 25% of total energy coming from protein could restrict growth, fetal growth, and result in small for gestational age babies. And I know that protein is something that we focus really strongly on in our bariatric population. I wondered if anyone had any comment on kind of that macronutrient balance and fetal growth after bariatric surgery.
That's the question also, I think, because we know that there is an increased risk, but the exact reasons are, as of right now, not really known. It is probably various factors contributing to this fact, like macronutrients, micronutrients, some effect of the surgery itself. It could be due to stress in the mother. I can name dozens of reasons why it could be, but I think the only real answer right now is that we don't know for sure, and the only thing that we can do is take a close look at our patients, make sure that their nutrition is adequate, that they don't have deficiencies, and then screen the babies for any problems.
All right, I have another question for you, very specific to the gastric band. In pregnancy, if the patient is asymptomatic with obstructive symptoms and is not suffering from any nausea, vomiting related to the pregnancy, would you advise to fully deflate the gastric band or leave some fluid in to prevent excessive weight gain?
I can take this one. There is actually some data on band management during pregnancy. And indeed, you have to be sure that there are no complications because band slippage has also been reported. So that's another one to look out for. But if there's no complications, then active band management appears to have a good effect on the gestational weight gain and good effect on fetal growth. So indeed, I would recommend using it as a diverse tool and adapting it as necessary.
All right. What's the best way to manage reactive hypoglycemia in pregnancy that seems to be resistant to all the usual advice like small meals, carbohydrate control, adequate protein? Any suggestions? From anybody?
I can tell something about it, but I'm certainly not the nutritional expert here on the panel. But in our experience, indeed, sometimes it can be very difficult in these patients. There are some drugs like acarbose that you can use to make sure that the uptake of sugars from the gut is slowed down, and sometimes you see a good effect on this. And yeah, it's always the same. Try to diminish your uptake, try to slow everything down, and hopefully you get somewhere. And in pregnancy, you can discuss with your patient that if they have severe complaints in the 3rd month, that it can be completely different in the 6th month because things change. So sometimes you only need small interventions and some patience.
I don't have any specific advice. Besides, if you follow all the routine things that you would usually do, and it may be worth consulting an endocrinologist in these type of cases if you think it's a particularly complex case and you've tried everything that you would usually do.
All right, I'm sorry, Dr. Koolmans, I don't mean to pick on you, but since you're the only male on this,
Yeah.
why are women with BMI less than 25 in higher risk during pregnancy compared to women with BMI greater than 25?
I don't know if the person who asked the question specifically means for patients after bariatric surgery or in general.
I don't know, does that relate to what I was talking about in relation to inter-pregnancy weight gain? That may be misconstrued slightly. I think in those who have a BMI less than 25, they may be at greater risk of not gaining sufficient gestational weight, so that could be one issue. The other thing I highlighted in the talk was with regard to inter-pregnancy weight gain. So this is in the general population, so that those who started off before the first pregnancy with a lower BMI, so a BMI less than 25, and between their first and subsequent pregnancy, they gain more than 3 BMI units, so let's say their BMI is now 29, they are at a higher relative risk for some perinatal outcomes in the subsequent pregnancy than someone who started with a higher BMI. So it's quite difficult to untangle, but if you read the 2 systematic reviews that I highlighted, perhaps it explains it a little better, but that is in the non-bariatric population, that's in the general population. So hopefully that addresses.
And I think both of the speakers also mentioned that like 56+% of people are gaining more weight than the IOM recommendations as well. And I always struggle with that a little bit because Dre's also talked about anxiety disorders after bariatric surgery as well. So if someone's predisposed to anxiety and you're trying to limit the amount of weight that they're gaining, that can become quite a trade-off or a bit of a dilemma as well. I wonder if anyone's got any more comments on that as well.
I always find that I'm very honest with my patients. I discuss the fact because I almost exclusively treat patients with pregnancies after bariatric surgery, just to be clear. And when we first see each other, I'm very frank about it, that I acknowledge that they did very extreme measures to get their weight under control, but that it was necessary because they picked a very bad ticket out of the lottery of genes, and they're just predisposed to it. And that is part of my job to acknowledge this severe thing that they did, and that we need to make sure that they have the best outcomes. That there are data that show that weight gain during pregnancy is important for her and for the baby, and that I will do my best to help them along the route. And in the end, when we're finally there and the baby is born, I'm not going to go to the maternity ward and discuss weight loss 2 days or 2 hours after the baby is born. That's a little bit cruel. But when I see them again after 6 weeks, we do discuss this. And I do tell my patients that we will discuss it then. And in general, I don't have any data on this, but I find that my patients do appreciate the honesty. And it's just the way how you talk with your patients about it. If you're very negative about their weight and their weight gain, then they will notice this. Whilst if you're just, well, appreciative, they often, in my experience, they often appreciate that also.
Thank you. And do you often use a psychologist to help you with that as well?
Almost always.
Yeah.
So we have a very strict follow-up of our patients in our clinic, in which they are routinely seen by me predominantly, but there's also a structural network around us, in which we work together with the endocrinologist department, with dietitians, and with psychologists to aid them in this. In the beginning of pregnancy, I always offer psychological support. Not a lot of people immediately accept this, but then they do know that it's a possibility. And oftentimes when we're halfway through the pregnancy, they do tend to ask for a consultation, and just to be sure.
Nice. It seems like you've got a really good wraparound team.
Yeah, a very comprehensive team. I agree with that. And then that just makes me curious in regards to your bariatric surgeons. Do you work very closely with them? You seem to be very well educated when it comes to bariatric surgery. Do you engage them when a woman becomes pregnant, or how does that work in your practice?
So in our hospital and in the Belgium setting, every patient that applies for bariatric surgery needs to be approved by the psychologist, the dietitian, this endocrinologist, and the bariatric surgeon, of course. And this happens on a meeting which is weekly. And in our hospital, I'm also there. And we discuss possible points. I also use this moment to search for patients that I can include in various studies. But otherwise, we can use this to address points if patients are at an age at which you think that they might want to get pregnant, so that we discuss this beforehand, and that they might see me on my consultation and I just discuss the various risks of pregnancies after bariatric surgery, but also the advantages of it, so that they know what's going to happen. And then when patients are happy, pregnant, and if there is a complication, we have a very good interaction with each other, so we can always call them and discuss things with them. And this is very important, I think, for your patients, that all your care providers know each other, and that there's no hesitance to calling each other with problems. So we do know each other all very well.
Very good. Now, there was a follow-up question, and this was part of the poll question that we had, is when do you recommend patients consider becoming pregnant after having bariatric surgery? And as you saw in the poll, most people recommend somewhere between 12 to 18 months. And I believe in your paper, you said when weight has stabilized. Is that any different? Any other recommendation from any of the panelists, including Dr. Ceulemans as well?
I'll go first. Very shortly, yeah, that's what we recommend. Wait until the weight is stabilized. And oftentimes you see in the literature that after sleeve or bypass, this is after 12 months. And for procedures like gastric banding, that this takes a little bit longer and might be 18 months. But I think if weight is stabilized, then that's the best that we can hope for. And after a while, you also just need to say, now it's a good time to become pregnant, because otherwise your patient gets older and older, and that can also give complications.
Right,
so
right.
Don't wait for too long.
Liz.
Yeah, I would just like to comment on that too. So I do appreciate that you clarified that as well, because it seems to be a little bit of a debate here in the United States. You know, do we recommend greater than 12 months or the range of 12 to 18 months? And the subject came up because what if you have, you know, a sleeve patient that needed to lose 50 pounds and she lost the 50 pounds in 6 months. Do we impose another 6 months or even longer to have her wait to become pregnant if she's at her goal weight and she's eating a variety in her diet and compliant with her vitamins? I know things need to be on an individual, you know, patient-centered approach. Of course, that's what we'll always do. But if guidelines are saying greater than 12 months, then that almost puts, at least here in the United States, maybe some medical legal jargon that might make a practitioner a little bit hesitant to say, okay, yeah, 6 months, you're ready. But to impose another 6 months, especially for a woman who is anxious to get pregnant or at an age where, you know, she needs to get pregnant soon, you know, we were just looking for a little bit more guidance on that. Did I make sense or did I ramble?
No, so I guess I'll follow up with that. But my understanding, even if she is at goal weight, that doesn't mean she's at a stable weight. And you want her at a stable weight. Is that for about 6 months? Is that right, Dr. Ceulemans? Or how long do you recommend?
So we recommend stable weight.
For how long?
I think you will notice rather fast when the weight has stabilized, probably if she has reached a sufficient weight after 6 months. If you wait for 2 or 3 months more, you see that the weight gain is stable, then you can be sure about that because, well, probably after, if you wait long enough, she will start gaining weight again, if we are very frank about it. So yeah, if just wait for a couple of months to see if everything is okay, and then she's good to go.
Here in India also, we generally would wait for at least 18 months. Like we don't really recommend anybody to plan a pregnancy till the weight stabilizes. So that is what even we follow.
I think that's just a tricky word. What does that mean? Weight stabilized? Because for some patients, they're never quite at the weight they want to be at either. So they might be pursuing more weight loss. So I think that's the tricky jargon.
Yeah. And I know that we always recommend that we wait until a stable weight, but in Kate's research, she found that I think it was about 28% of people became pregnant within their first year after bariatric surgery. So a lot of those probably aren't at a stable weight. So how do you manage that? They're still losing weight due to the surgery and then gaining weight due to the pregnancy. How do you balance out that?
Yeah, I think in the graph I showed, you could see it's very crude. Though we had the BMI, highest BMI at booking appointment was around 8 weeks pregnant, and then BMI afterwards. So that actual point in between, when we were doing that study retrospectively, we didn't always have that lowest weight because a lot of time people became pregnant before they had reached their goal weight, as you said. And I think it probably comes down to, when we're looking at the data, in the UK, for example, you know, weight isn't necessarily monitored in pregnancy all the time unless there's high risk. So you know, I don't know what the best answer is. That it probably, it also is to do with whether the pregnancy was planned, and how, you know, how late into the pregnancy the person realizes all of that. So it's very difficult to narrow down.
Fair, that's fair. I have a question here on vitamin D. There's some debate currently about the level of vitamin D to aim for during pregnancy. Does the panel have any thoughts on this?
Do you mean in relation to supplementation or monitoring, biochemical monitoring, or both?
I'm not sure who sent this question in, if you have follow-up information in regards to it, or if you have any thoughts on from the panel in general.
Yeah, I think so. I think that the ASMBS recommendations are 3,000 international units a day, and I know that the non-bariatric pregnant recommendations are about 400 international units a day in New Zealand, but they also think that that level is probably on the conservative side as well. And for the non-bariatric population, it's probably more 1,000 to 2,000. So we still aim for the bariatric level of 3,000 in New Zealand.
Okay.
I think just a follow-up question to that, sorry to cut you off, Karen. Is there any concern on over supplementation for a mom that's breastfeeding? Just because in some of the bariatric literature on that rebound hypervitaminosis that might occur with breastfeeding babies. So because some of the levels of the supplements are so much higher for bariatrics, what's your opinion on breastfeeding with those higher levels? Are they being conferred to the baby and perhaps causing a hypervitaminosis?
So the systematic reviews I looked at basically said if there's any mild to moderate variation in intake, and that could be from supplements or food, it's not going to have a very demonstrable effect on the milk content, but it's at the extremes. And I don't think we have that data, to be honest.
Yeah.
It depends what
That'd
the
be an interesting study.
yeah, and also it depends whether the person has had their blood levels checked as well after pregnancy, which may or may not happen routinely. I don't know if anyone else wants to comment on that. Yeah, we have some data on the breast milk macro composition, which you also showed in your slides. But what's very important at that moment is that we did not have that specific supplement yet at that moment. So patients were taking a normal multivitamin with various things added to it if necessary. So as mentioned, we don't know for sure what's going on in patients who are hyper supplemented and then breastfeeding. In general, breast milk appears to be this very magical substance that always comes out right. So I'm not too overly worried about it, but it needs to be investigated, of course, to be sure. But in my opinion, breastfeeding can be safely recommended to all patients after bariatric surgery, certainly as there are data that show that infants born to, well, in general, breastfeeding protects against obesity on later ages. This is also been shown to be possibly true in infants born to bariatric mothers. And if you then take into account that these infants probably don't have the best genetic profile for obesity, all these small things that we can do to aid them along in their further life can be of tremendous impact.
Thank you.
Yes, thank you. And I do have that follow-up in regards to the vitamin D question. It was relating to monitoring. In the UK, advice used to be to aim for levels above 50, whereas there's been discussion as to whether levels should be above 75.
Yeah, so in the paper I presented, we used 50 as the cutoff for insufficiency and 25 for deficiency. And I know there's lots of debate about this in pregnancy in general. I don't know how that relates to your places, whether you use 50 or 75.
It's 50 here in the USA. That's the cutoff.
It's 50 in New Zealand as well.
We have quite a few.
I think there's a lot of
related to vitamin A again. If there is vitamin A deficiency, do you recommend supplement with a retinol form or a beta carotene form?
In general, I would recommend using beta carotene. The retinol form, of course, is known. Well, there are some worries that it could be dangerous for the baby, but the limited evidence that is there shows normally that you would not expect an effect if you stay below 5,000 international units a day, but this is very limited. So, and I think during pregnancy, you'll find that most obstetrics really don't like seeing the words retinol palmitate even associated to the pregnant mother in any way. And beta carotene is also an excellent way of supplementing it without really having the risk of over supplementation. So if you have the choice, I would go for that.
Yeah, I think you've got to be really careful as well about the time during pregnancy. So it's first 60 days during pregnancy where the retinol is thought to be like particularly bad or can cause birth defects. After that, if you've got the option to use beta carotene, I think that's good. Yeah, if retinol's all you've got that's available, that could be an option as well. And as Dre said, less than 5,000 international units a day.
Thank you.
What I find very interesting, though, when you look at some of the prenatal over-the-counter vitamins, say for vitamin A, they're not using all beta carotene. They're not using retinol, of course not, but they are using a combination of retinol palmitate and carotene as a combo, and that's in a prenatal vitamin. So perhaps the retinol palmitates are on the same line as beta carotene in terms of safety, I would think, if they're in a prenatal vitamin.
And interestingly, in New Zealand, our most common prenatal multivitamin has got no vitamin A in it whatsoever, which I think is a mistake.
Okay, staying on the vitamin topic here, vitamin B12. Any concerns about B12 deficiency for breastfeeding? Is there any impact on infant B12 if there's higher levels or lower levels? We have seen deficiency in breastfed infants or of deficient mothers following vegan diets.
So that was one of the deficiencies that was highlighted in the case reports, but it was generally in combination with zinc and a whole host of micronutrient deficiencies. I think, you know, as long as the person is having their levels monitored and they're having their injections as they should be, that's probably the key message we should be giving.
How about calcium? Another vitamin question. What is it about calcium supplementation during and after pregnancy?
So I think having a low calcium level can increase your risk of preeclampsia, so particularly if your total calcium is under 500 milligrams a day. So it's something that I always do a check for in my consultation. The other thing that I find really useful with calcium supplementation is a lot of the anti-reflux medications have got calcium in them as well. So if someone's got reflux, we can often get some useful calcium into them through their anti-reflux preparations too.
All right. Kate mentioned a high proportion of patients becoming pregnant in the first year after surgery, about 28%. This is always a difficult conundrum as the surgery is contributing to weight loss, and this is being offset by pregnancy weight gains. Do you have any comments on this?
I think we already covered this to a certain extent, just in terms of at what point you measure. So you're going to get a different, depending when you measure weight, you're going to get a different outcome as to what's gestational weight gain and what's the highest weight and what's the lowest weight achieved. But I think we've already covered this to a certain extent, unless anyone else wants to add anything.
All right. And we've also talked a little bit about weight loss, but specifically when to do weight loss surgery after pregnancy. What about non-surgical weight loss? What type of recommendations does anyone have in regards to that?
Not really my topic.
So do you mean using, you know, pharmaceutical methods or lifestyle methods, or?
Any or all of the above. Now, certainly we want to take consideration if they are breastfeeding, and certainly don't want to use medications that would be harmful to the baby. But any other recommendations in regards to weight loss options for non-surgical options for the weight gain during pregnancy? Has anybody found anything really successful, particularly for our bariatric patients who struggle with the excess weight gain?
I would have. You can take it.
Something that we are looking into as a research group is the use of, or actually no, not the use of it. So we're investigating the use of Saxenda in people who are, you know, the fact it shouldn't be used prior to conception, during pregnancy and during breastfeeding. So that's something that we're looking into to find out what is known about that, and, you know, whether people are, how they're using that information. So, and how it should be used in people of reproductive age who want to become pregnant at some stage.
I think for the pharmacological treatments of overweight and obesity, there's not a lot of data on that in pregnancies. So we don't really know. In general, of course, you would always be more happy if our patients have a normal weight or a healthy weight when they try to conceive, because as I've shown also during my presentation, the risks of complications are very high, well, very high, are higher if your BMI increases. But the way how you do that, I think that's the age-old question also. For those patients who have like a BMI of 28, how do you really deal with that on a sufficient way with a good weight loss that has long-term positive effects? I think the final word has not yet been said on that topic. And we'll just have to wait and see a little bit what goes on in pregnancies. Now, of course, in pregnancy itself, we also have one extra worry, which is the theory of the intrauterine programming, of course. So we want our patients to have a normal weight. We want our patients to have sufficient nutrition during pregnancy, as it is known that if our patients have undernutrition or any type of placental problem, that the baby itself might be affected by this and might have a selection of genes with epigenetic changes, which might result in a completely altered metabolic profile and greatly influence the risks of developing diabetes or obesity at a later age, even in next generations. So that's always something to take into account, of course, if you're actively trying to lose weight and you're trying to conceive.
Okay, we are coming very close to the end here. I'm going to take one more question and then we'll wrap this up. Well, I think we don't have time for that last question, and I apologize. Let's go ahead and wrap this up. I've got to thank you all for being on this webinar. This has been a lot of information, very much needed, and I'm sure we're going to have more to come in the future, and fingers crossed that we'll have that information. Thank you all for attending this. This has, again, been such a pleasure to moderate this, and I look forward to more collaboration with all of us across the world here. Happy Earth Day, and thank you again for this. Everybody have a great day. Thank you so much.
Thanks, everybody. That was
Thank
great.
you.
Bye.
Bye.
Bye. Bye.
Bye.